Okay, so you guys seeing just my slides now? Okay, great. Well, like Renee said, my name is Fawn Goodell, and I am with the Public Children's Services Association of Ohio, and I serve as the director of the Ohio START program. And I'm here for a few minutes to talk a little bit about what it is that we do, and how we serve families across the state of Ohio. Um, so I am happy to answer any and all questions about Ohio START at any time. So I'm not sure how you all typically do this, but if you want to interrupt me, feel free to do so or save your questions for after. Either is fine with me. All right, so if you aren't familiar with the START model stands for Sobriety, Treatment, and Recovery Teams. There's a national START model. In Ohio, because we have to do things a little bit differently, we changed it to Sobriety, Treatment, and Reducing Trauma because we wanted to really focus on trauma and reducing the trauma of all the family members who are affected by substance use disorder. But the START model was born in the 1990s in Cleveland, Ohio, with support from the Annie E. Casey Foundation. And this was at the time when the crack epidemic was going on, and Cuyahoga County Children's Services realized that they needed to do something differently in order to engage with families in a more productive way, because it was also at the time when new federal legislation was passed that required children's services to terminate parental rights within 2 years if a child had been in care for 2 years. And for those of us that are familiar with substance use disorder, we know that 2 years is a really short amount of time for folks to make a full recovery. And so the timelines weren't adding up, and so Cuyahoga County realized they needed to do something different. And so out of that need to do something different, they collaborated with many community partners and created the START model. It was successful in Cleveland for many years. And then the lady, Tina Willauer, who was in charge of START in Cleveland, was recruited by Kentucky to come down to Kentucky in 2007 because they were starting to see the beginning of the opioid epidemic in Kentucky. And again, realized that they needed to do something different in Kentucky to address parental substance use disorder and how they were engaging with families and children's services. So the model was then taken to Kentucky, and they got several federal grants where they were able to write a manual, have some federal studies done on the model, and really kind of firm up the research behind the model and establish it as a national model. And you can see that today we have START teams in Kansas, Nevada, New York, North Carolina, Maryland, Montana, that's a tribe, so that's pretty cool, and Ohio. Ohio is the largest implementing site. We are implementing in 57 counties here in Ohio. And this map shows the counties that we're currently implementing START in. The gray counties are those that are in pre-implementation, so we say they're kind of dipping their toe into the implementation of START. They're just beginning to explore what that might look like. And this map needs updated. We've recently added Claremont and Belmont, I'm calling them the Monts, to pre-implementation. So I need to update the map. They should be gray also. And then the lighter blue colored counties are those that are in various stages of implementation. So that means they could just be starting to set up their teams. They could be serving, having served just a few families, or they could be in full implementation and been serving for a while. So they're in various stages. And then those dark blue counties are those that are certified. So that means that they have met model fidelity and have been certified by the national purveyor of the model. So as you can see, we have counties that are in various stages of implementation throughout the state of Ohio. So now that you know where we're at and where we came from, what the heck is the START model? So the START model is a evidence-based model that serves families that come to children's services due to parental substance use disorder. And the model is based on these key components. And the first one is early identification of families. So families that come into children's services, because of a phone call or report that a child is being neglected or abused due to parental substance use can be referred to start. They have to be referred to start within the first 14 to 30 days of the start case of the case opening with Children's Services. So that's a very tight timeline for us. That after they are referred to the start team, we require them to get quick access to SUD treatment. So they need to be assessed and have their first 4 SUD treatment services within the first 38 days of the case. And so if you know anything about Children's Services and how we have traditionally operated, this is very quick. So typically a case would be open for intake for 30 to 60 days and then referred on to ongoing. And then we would ask the family to get an assessment, which there might be a wait list for that. And then once the assessment tells us what the parent needs, we would refer them on for services, which again, there could be a long wait list for. And so, it could often be 6 months before a parent could begin that treatment that they may need. And what we realize and start is that you can lose the parent in that amount of time. We really feel like at the point of case opening, it's a point of crisis and a time that we could really engage with families and get them in quickly to treatment. So we work really hard to wrap services around them at the very beginning of the case and throughout the rest of the life of the case, but at the very beginning to get them in quickly to services so they can begin treating that SUD so the kiddos can be safe. And this kind of goes back to what I was talking about before about our need for urgency when we're working with families that have SUD because of our federal timelines where we have to make a decision about permanency for kids at the 2-year mark, which again is very quick for families. So that sneaks up on us, right? So the model also requires weekly home visits by both the START caseworker and the START family peer mentor. We'll talk a little bit more about both of those roles in a minute, but that means that the family is getting 2 home visits per week for the first 60 to 90 days of the case. In a typical Children's Services case, they're getting 1 visit per month. So this is a lot more oversight and a lot more hands-on with the families, working really closely with them and helping them move through the process. We also are basing a lot of our work on shared decision making, and this means shared decision making with the family and with all the team members. So we have family team meetings throughout the life of the case, very early on, every 90 days, and at any point where there is a need for decisions to be made. And we really have families lead those meetings and have them bring folks to the table that they want to be part of those decision-making processes. And then finally, rigorous evaluation. We partner with the Ohio State University School of Social Work and OU to evaluate Ohio START to make sure that what we are doing is working for the families and kids that we are serving. Our goals are aligned with the Department of Children and Youth and their goals for all families that we're working with. Our number 1 goal is that children remain with the parents if it's safe to do so. And if they have to be removed, we want them to be reunited with their parents as quickly as we can. Again, safety being the paramount concern, but we know that kids do better when they can remain with their parents, and there's less trauma for the kids and their parents if they can remain safely with them. So that's our number 1 goal. We also want to reduce child maltreatment, increase parental recovery. That goes with safety and keeping the family together. We want to increase permanency for children. So if unfortunately the children cannot remain with their parents because it's not safe to do so, we want to make sure that they're going to achieve permanency in another way so that they have permanency at time of case closure. We also focus a lot on family stability and self-sufficiency so that once the case closes, that family is able to be successful on their own. And we hope that they won't have another case that opens with Children's Services. We want them to be successful and not come back into the system. And then our final goal is to work on systemic improvement. This is a model that not only works with Children's Services, but looking at the system in general of how we work with families with SUD and how we can make things better. So I told you we would talk a little bit about that Ohio Start team. So the Ohio Start team is comprised of a child welfare worker and a family peer mentor, and we call that the dyad. And a dyad carries a capped caseload. They carry a caseload of no more than 12 cases. And they are jointly working that caseload together. So the child welfare worker and the family peer mentor have the same 12 cases. They're working all of those cases together. We call it like a marriage. They are doing everything together with those START families, and they're carrying a lower caseload than a typical caseworker would in children's services. And that's because we're asking more of our dyad. They're much more involved with the families. They're doing a lot of more intensive wraparound work with that family. So they need to be able to dedicate the time to that family. The family peer mentor is co-located in the Children's Services Agency. They are part of the Children's Services team. They work hand in hand with that caseworker on all things. And the team is really based in partnership. The family peer mentor and the child welfare worker are really jointly working to make sure that the family is getting everything that they need. So who is a family peer mentor? A family peer mentor is someone that is in long-term recovery from a substance use disorder. And also, we want them to have children's services experience. We have many family peer mentors who were actually clients of the agency and or caseworker that they're currently working with when they had a case open with their children due to their substance use disorder. They are what I call the secret sauce or the magic unicorn or whatever you want to call it, but they're what makes the difference in START. They are there to help parents navigate the children's services system, the court system, recovery system, all the different systems that our parents are touching. Our peers help navigate those. They are able to engage with our families early, often, and in a better way than our children's services workers can, because they understand what that family's going through. They've been there, they've done it, and they can really just, touch base with them in a way that caseworkers can't. I'll hear caseworkers say, I said X to the family and they just had blank stares. And then the family peer mentor said the exact same thing and it clicked and the family was engaging with us. So they just are really able to get to the heart of what's going on. They introduce parents to recovery supports. They get them connected with the recovery community in their area. They do not serve as their like sponsor or anything like that, but they will get them connected to that type of support if the family wants it. They make those face-to-face visits, like I said, at least once a week, but I often hear from our peers that they are in contact with their families daily, talking to them about what's going on and offering support. They also will support relatives who are caring for the children, help them navigate how to best support their relative who's going through recovery. And they have just intensive involvement with the entire family. A lot of what the work that they do at the tail end of a case is helping parents know and learn how to parent sober. So sometimes our parents have never done that, and that can be difficult. That's a lot of the work of the peer mentor. Like I said earlier, START is really family-centered practice. We believe that the parents are partners in change, and we're not just recipients of service. They are intimately involved in the decision-making that's going on in the case because we really believe that that's how you get buy-in and that's how you get change. If they're leading the process and helping to drive the change, then they're not feeling like they're being forced to do things that they don't want to do or aren't necessarily healthy or good for their family. And that's really a central part of the work that we do with folks. This slide is really about the way that we think about recovery. We know that substance use disorder is not just a one-person disease. It's a disease that affects the entire family. And we look at family recovery from a family lens, and it's not just about negative jug screens. It's about so much more. So when we're working with the family, we are looking at all of these different items that you see listed. You know, are they improving their parenting skills and competencies? How's the parents' mental health? Have they engaged in mental health services? Are they doing well in that space? How are they doing with housing and transportation? Are they able to be self-sufficient? Looking at the child's well-being, how are they doing? How are they doing in school? Do they need services to address their trauma? Because we screen all family members for trauma, including the kiddos at the beginning of the case. So are they getting the services that they need? And these are all the different items that we're looking at when we're thinking about how the family is progressing in their recovery timeline. And certainly at case closure, are they ready to think about case closure? And then I touched on this a little bit in the previous slide, but we in START really believe that it's the role of the START team to think about systemic change and the way that families with SUD are engaging with children's services in general. So we have steering committees at each county that are looking at how can we improve the systems that are serving our families. What services are available within that community to engage with folks with SUD, and how can we leverage our combined resources to make it better. So things like, do we have the services that families need? Do we have inpatient treatment close by so families aren't separated when they need to engage in that type of service? We've had counties that have built relationships with YMCAs so that the parents and families can engage in healthy activities outside of school. We've had, counties that have addressed transportation barriers, that type of thing. All of the different resources and relationships that impact our families, and not just START families, but all families with SUD that come into the children's services space. And my last slide is, here are published outcomes from Kentucky. And their study showed that when women in START had nearly double the sobriety rate of those that were not in START, children were about half as likely to enter foster care. And at case closure, 75% of START kids remained with or were reunified with their parents. We're seeing in Ohio, our percentage is in the 80s of the number of kids that are with their parents at case closure. And so we're really encouraged by that. We also have done some Ohio studies that have shown parents have improved parental capacity, and Kentucky showed that for every dollar spent on Kentucky START, $2.22 was saved in foster care costs alone. That didn't take into all the other costs that come, cost savings that come when families are kept together and parents are in recovery and doing well. So we are hoping to have our Ohio outcomes published later this year, so stay tuned. And we anticipate we will see great results also. And that is my last slide, so I'm going to stop sharing.